Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ipsen.
This program is presented by Medscape Education Global.
Hello, I'm Eckhard Sturm. I'm head of the Pediatric GI and Hepatology section at the Children's Hospital, University of Tübingen in Germany. And I welcome you to this program entitled Differential Diagnosis of Pediatric Cholestatic Liver Diseases. And what we'd like to discuss with you in the following minutes is to get a practical approach to this topic. And I'll start this program with a brief introduction, and this is followed by 3 contributions from colleagues. Dr. Amal Akul will discuss best practices for the diagnosis of PFIC diseases, followed by Dr. Claudia Mandato, and she will address best practices for the diagnosis of Alagille syndrome. And the last contribution will be given by Dr. Amber Hildreth, who will present an approach for the diagnosis of biliary atresia. And finally, I will close the program with some concluding remarks. So to start off, let's talk about the definition of cholestasis. Back in the 1970s, a couple of decades ago, Hans Popper, whom you all know, the godfather of cholestasis and cholestatic diseases, had a definition of cholestasis depending on different observers. So the morphologist might define cholestasis as an accumulation of bile in cells and biliary passages. The clinician might look at it as a piling up of biliary substances in the blood. And the radiologist may look at it as a visualized obstruction of the bile ducts, whereas the physiologist might speak of an inhibition of hepatocellular secretion of all bile constituents. Now, a couple of decades later, in 2017, there is more or less a functional definition of cholestasis. Now it is more or less defined as a state of reduced bile formation or flow, resulting in the retention of biliary substances within the liver, normally excreted into bile and destined for elimination into the intestinal lumen. And the reason why now we have a rather functional definition of cholestasis is that we know so much more about the enterohepatic circulation, which is really the core issue about bile acid transport and cholestasis. This is a highly orchestrated system with molecular determinants of bile and bile flow, starting with the transport of bile acids from the hepatocyte via the canalicular membrane by a specialized transporter, the BSEP protein. And the BSEP protein transports bile acids into the canalicular lumen, where they, via the extrahepatic bile ducts, finally get to the intestine, where a reuptake is taking place in the terminal ileum by the IBET protein. They're shuttled back to the liver, and in the liver, on the basolateral membrane of the liver cell, the specialized protein NTCP is transporting the bile acids, the conjugated bile acids, back into the liver cell. Unconjugated bile acids are taken up by other proteins not specified here. So this really closes a very highly orchestrated loop. Let's not forget that the kidney is also involved into this enterohepatic circulation. And this is especially important for times of stress and disease. And if we talk about disease, we have to realize that there are different cellular compartments in the liver where the diseases may manifest. There are the hepatocytes on one hand, and in the hepatocytes, especially on the canalicular membrane, we know that diseases like PFIC diseases 1 and 2 manifest, but also type 3 manifests itself on the canalicular membrane. As you know, this is a defect in phospholipid transport into the bile, but you should keep in mind that the manifestation of this disease is actually the bile ducts themselves, because this deficiency leads to chronic cholangitis and sclerosing of the bile ducts. Other diseases like biliary atresia and Alagille syndrome manifest indeed primarily in the bile ducts. And let's talk about the tools that we have in hand in order to differentiate those diseases. And here's a case I'd like to discuss with you. It is a 12-week-old female infant. She's jaundiced. We do not note hepatosplenomegaly. She has a direct bilirubin of 4.3 and no murmur indicating heart disease. So how do you go about in trying to come up with a cause for the cholestatic disease in this patient? First, of course, you need to know that clotting is intact, because you know that malabsorption of fat-soluble vitamins, and in particular vitamin K, can lead to severe disruption of clotting and manifestation as an intracranial bleed. Next, of course, it is important in a timely fashion to exclude biliary atresia. And you can use screening tools for that purpose. You can use the stool color card, which has been implemented in many national health systems. And in some cases, you might want to know in more detail whether biliary atresia is manifesting itself. In that case, imaging techniques may be quite useful. And in our center, we use ERCP for that purpose. It is also important to exclude alpha-1 antitrypsin deficiency, which might look very much like biliary atresia, and often it's not so easy to discriminate those two. Parameters like gamma GT may give you important information. When gamma GT is low, keep in mind this is a parameter of low specificity. You might deal with diseases like PFIC types 1 and 2 or bile acid synthesis defects, whereas in Alagille syndrome and PFIC type 3, gamma GT activity might be significantly elevated. Bile acids are important parameters to check. On one hand, they might give you an indication for bile acid synthesis defect as the problem, but they're also important parameters for the follow-up of the patient on treatment. And then you have extrahepatic features of disease. Especially in older patients, like in this boy, you see that the facial appearance may lead you towards the diagnosis of Alagille syndrome. Everybody knows how to handle liver biopsy, of course. Liver biopsy is an important tool. It's the only way to look into the liver. And you see here 2 examples of findings in liver biopsy. These are striking examples of fibrosis in the portal fields on one hand and neonatal hepatitis in the other example, but the specificity is only moderate. So in our algorithm evaluating these patients with especially neonatal cholestasis, once we have excluded biliary atresia, very quickly we proceed to tools that we have learned to use from next generation sequencing. And we have learned that in our center we use whole genome sequencing. Meanwhile, we have learned that this testing can increase the diagnosis rate and enable very early diagnosis of a whole range of different genetically determined diseases relevant to cholestatic disease, like PFIC diseases on one hand and diseases of the bile ducts like Alagille syndrome on the other. I would like to raise one important symptom in children with cholestatic disease. This is pruritus. As you know, bile acid accumulation can lead to pruritus, and this in many diseases such as Alagille syndrome may be a major symptom of cholestasis. So it is important to identify the symptom early and treat very effectively in order to help the patient gain control of a better quality of life and regenerate. So why we should really try to not delay the diagnosis of cholestatic liver disease and look for a specific etiology, because if we miss that, it is very likely that disease can evolve and fibrosis can evolve into cirrhosis, which might then lead to the need for organ replacement. Additionally, we have to keep in mind that we should do our best to maintain a high quality of life for the patient and the family. And for this purpose, we might use novel drugs that are quite helpful. And in order to give you a more detailed introduction into this field, I propose that we go on to the next chapter, where Dr. Amala Kul will discuss best practices in diagnosing PFIC type diseases. Thank you very much, and I'll talk to you later.
Welcome, everyone. I'll be happy to talk to you today about the best practices in the diagnosis of progressive familial intrahepatic cholestasis, or PFIC. My name is Amal Kul, and I'm an associate professor, director of hepatology, and director of liver transplant at UT Southwestern Medical Center in Dallas. So progressive familial intrahepatic cholestasis represents a group of heterogeneous autosomal recessive disorders that are caused by mutations of the gene involved in canalicular hepatobiliary transport, resulting in disruptions of bile homeostasis, which eventually leads to cholestasis, cirrhosis, liver failure, and death. The subtypes group based on the underlying genetic deficiency. So, for example, ATP8B1 deficiency can lead to what's known as PFIC1, or ABCB11 deficiency can cause PFIC2, and ABCB4 deficiency can lead to what's known as PFIC3. Most recently, new pathogenic variants are identified and are linked to new subtypes of PFIC. PFIC affects 1 in 10,000 to 1 in 50,000 births, typically diagnosed within first few years of life, though some versions are milder, which can have later onset. It's inherited an autosomal recessive pattern. However, individuals with heterozygous mutations may present with transient neonatal cholestasis, or older in life when they have intrahepatic cholestasis of pregnancy or drug-induced liver injury. Even simply cholelithiasis can be also associated with some of these mutations. In most cases, PFIC 1, 2, and 3 will progress to liver failure before adulthood and are usually fatal if untreated. The mortality estimates range from 0 to 87%. The clinical presentation is variable, and it's again based on the genetic mutation. So the clinical presentation can be a very broad spectrum, ranging from neonatal cholestasis or some non-progressive intermittent cholestatic jaundice to chronic liver disease. Cholestasis commonly presents in the first year of life, and the main hallmark of these disorders is pruritus or itching, which can sometimes be severely debilitating, leading to poor quality of life. The lack of adequate intestinal bile may cause fat malabsorption and eventually fat-soluble vitamin deficiency, leading to malnutrition, low bone mineral density causing osteopenia or osteoporosis, or vitamin K-responsive coagulopathy, in addition to complications of vitamin A or E deficiency. Elevated serum bile acids is characteristics of these disorders. In some of these disorders, there might be presentation of this genetic mutation outside the liver that lead to extrahepatic manifestation, including deafness, pancreatitis, or short stature. In PFIC3, cholestasis leads to impaired copper excretion in bile and may lead to hepatic copper accumulation and increased urine copper excretion, which can be misdiagnosed as Wilson's disease. In addition to the clinical picture on examinations, patients might found to have hepatosplenomegaly and on imaging as well. And end-stage liver disease might be the initial presentation. And in certain types, liver cancer can be the initial presentation as well. In this table, I will be highlighting some of the heterogeneity in presentation among the most common 3 types of PFIC, which represent about 10% of the causes of neonatal cholestasis. The common thing between the PFIC1 and PFIC2 is they have low GGT in comparison to the PFIC3, which has a high GGT. Patients with all types can present as early as birth. Typically, type 1 and 2 PFIC are diagnosed in the first 6 months of life. Same for PFIC3, but PFIC3 can also be diagnosed in adolescent or in adulthood. Patients with type 2 and 3 can progress to liver cirrhosis within 6 months of diagnosis. And type 1 can be associated with extrahepatic manifestation, including diarrhea, hearing loss, and pancreatitis. Pruritus is commonly seen in all 3 types, with cholelithiasis, and hepatocellular cancer can be seen with type 2 and 3. So how can we make the diagnosis of these disorders? For many years, diagnosis has relied on clinical features, liver histology, and immunohistochemistry data. However, with the presence of targeted genes testing that improved the diagnosis, as these were sent whenever there was a concern based on the clinical picture. And now there is a commercially available cholestasis gene panel that can test up to 77 gene mutation that has been associated with cholestasis. Biliary atresia and structural defects has to be excluded first before the gene is sent. And now whole exome sequencing and whole genome sequencing are also readily available, which can help in certain situation where the clinical picture is suggestive and the cholestasis gene panel did not reveal a specific mutation. Now I will be talking about some of the clinical cases that I've seen in my own clinic. The first case is a Hispanic male who presented at 7 years of age with what was thought at this time to be an acute liver failure with elevated liver enzymes, hyperbilirubinemia, hyperammonemia, coagulopathy, and ascites. Because this patient was never known to have chronic liver disease, because he was previously healthy, we thought that this is probably an acute liver failure. However, with his abdominal imaging and the lab value came back suggestive that he might have an underlying chronic liver disease, because his imaging showed a nodular cirrhotic liver, he had a big spleen, there was pancytopenia on his blood count with some evidence of portal hypertension in his examination as well. Additionally, there was a reported family history of 2 maternal uncles who passed away at young age because of some liver disease of some sort that was never identified. So together with the presence of this chronicity, and additionally, the patient had elevated serum bile acids, which was in the 300s. So all of these together were pointing out that the patient is probably having an underlying chronic liver disease and perhaps a cholestatic liver disease. So his blood work showed low ceruloplasmin. So we sent for a urine copper, 24-hour urine copper, which came back elevated. The patient underwent a liver biopsy, and the liver biopsy showed also an increased hepatic copper in the biopsy. So that was concerning for Wilson's disease. But because we know that some of the cholestatic liver disease can have this issue, there was also a concern for PFIC3. So we sent for gene testing for both Wilson's disease and PFIC3 at that time. And in the interim, while we're waiting for the results of this genetic testing, liver biopsy and explant, because the patient underwent a liver transplant, showed finding on the histological examination, which consistent with liver cirrhosis, marked hepatocellular and intracanalicular cholestasis, marked cholangiolar proliferation with chronic inflammation and biliary cirrhosis, which again is pointing to cholestatic liver disease, but also can be seen with Wilson's. What helped us identify that this was concerning for PFIC is the MDR3 immune staining, which luckily showed weak staining consistent with PFIC3. This can sometimes be positive in some cases, but not in all cases, because sometimes patients who have the PFIC or genetic mutation might have the protein, which again, the immunohistochemistry staining will show, but the protein is non-functioning. But in this situation, the protein was partially absent, and this is why the immune staining showed weak staining. Gene testing came back, and the PFIC3 gene showed a novel, apparently homozygous variant of the ABCB4 gene at an evolutionary conserved size, which suggests that this is a pathogenic mutation. Interestingly enough, the sibling who was 8 months old at that time had splenomegaly, and gene testing was sent, and he had the same homozygous mutation. Eventually, this 8 months old boy grew up to develop chronic liver disease and eventually was transplanted at 9 years of age. The second case is also talking about a Hispanic male who presented to GI at 12 months with malnutrition, rickets, and diarrhea that eventually resolved. At this time, the concern that he might have gastroesophageal reflux disease, he was referred to feeding program until he was 19 months of age when he started having pruritus or itching. So that prompted workup, and labs were sent, which showed mildly elevated transaminases. So he underwent an ultrasound, and the ultrasound showed normal liver. But because of the pruritus, the elevated liver enzymes, further workup was sent that included the serum bile acids, which came back elevated in the 400s. So that again was concerning that the patient might have some genetic cholestatic liver disease. So a jaundice chip at that time was sent, which came back showing heterozygous mutation on the ABCB11 gene. One of these mutations was classified as a pathogenic mutation. The other one was classified as variant of unknown significance. So with one mutation in autosomal recessive disease, we had to confirm the diagnosis. So a liver biopsy was performed at 4.5 years of age, which showed mild to moderate periportal and lobular inflammation and pericentral fibrosis. Immune histochemical staining of the BSEP protein at that time showed absent BSEP, which luckily again confirmed the diagnosis of PFIC type 2. The patient within 18 months developed evidence of worsening liver disease, profound jaundice, coagulopathy, and portal hypertension with progression, and eventually received the liver transplant. So in summary, PFIC are heterogeneous group of disorders that result from disruption of the bile secretion and lead to cholestasis, pruritus, and progressive liver disease. Elevated serum bile acid is characteristic for these disorders. Liver biopsy can be helpful in certain situations, but the finding can be very general. Luckily, if the immune histochemistry stain is positive, it can help definitely confirm the diagnosis. Now with commercially available cholestatic gene panel and WES, we can confirm the diagnosis. Now moving on to the next chapter with Dr. Mandato, we'll discuss the diagnosis of Alagille syndrome. Thank you so much for allowing to present today about PFIC.
Hello, I'm Claudia Mandato, an Associate Professor of Pediatrics and Director of Pediatric Residency School and Head of Pediatric Pathology and Nutrition Section at the Department of Medicine, Surgery and Dentistry, Scuola Medica Salernitana at University of Salerno in Italy. Welcome to this chapter titled The Best Practices in the Diagnosis of Alagille Syndrome. Alagille syndrome is a rare disease. The current estimated incidence is approximately 1 to 30,000 to 1 to 45,000. However, the phenotype is really pleomorphic, so the incidence could be underestimated. The liver-related features include cholestasis, which in the liver patient is present from 87 to 100% of patients. However, jaundice is not always present. The patient could have cholestasis without jaundice. We can find cirrhosis and between the 15 to the 47% of patients undergo liver transplantation. The pathogenesis of the disease is complex, and it involves the JAK-NOX signaling pathway. You can see in this slide the panels that explain the NOX signaling pathway and its role in Alagille syndrome. In the top left panel, we can see the normal interaction between JAK1 and NOTCH2 that lead to the translocation of the NOTCH intracellular domain to the nucleus, where it participates in the transcriptional regulation of NOTCH2. In the top right panel, you can see the effect of JAK1 mutation, which prevents the activation, the cleavage of NOTCH2, disrupting the transcriptional inputs. In the bottom left panel, you can see a normal hepatic triad consisting of hepatic vein in blue, hepatic artery in red, and bile duct in green. This is the normal development of liver veins, artery, and bile ducts. When the JAK-NOX pathway is not well regulated, we can note the absence or the reduction of bile ducts, which is a hallmark of Alagille syndrome due to mutation affecting the NOTCH pathway components. So what are the key symptoms of and clinical manifestation of Alagille syndrome? Let's start from a clinical case. This is the case of a 3-year-old boy with a history of atopic dermatitis, and which was referred to itching and skin lesion. He also had a history of bicuspid pulmonary valve, and before performing the skin biopsy, he underwent two blood tests, which revealed an hypertransaminemia with hypergamma GT. The child arrived with his father. He was 32 years old. He also had a history of atopic dermatitis, and he underwent a heart surgery for pulmonary stenosis. He also had a history of hypertransaminemia, and for that, he underwent liver biopsy, which was not diagnostic. He also suffered back pain, and both received diagnosis of Alagille syndrome together. The son at 3 years old, but the father was 32 years old. In details, the clinical feature associated with Alagille syndrome, including hepatic involvement with cholestasis, jaundice, and bile duct paucity. It is relevant to note that the bile duct paucity is present in 70% of patients. So it is possible that a patient like the one I described to you have not bile duct detected at the liver biopsy. Present as well. The cardiac involvement is very common with up to the 94% of patients, and primary it is related to pulmonary artery stenosis, but also to tetralogy of Fallot. The patient could also present renal dysplasia or tubular acidosis, and also vesicoureteric reflux. There is also non-cardiac vascular abnormalities. It is very important for the risk of cerebral hemorrhages of these patients. And also the patients can present anomalies of great vessels. The skeletal abnormalities are very typical of the disease. Mostly the butterfly vertebrae, characteristic of found in 33 to 66% of the patients. What is really typical is the fascias, the dysmorphic features with a prominent forehead, deep-set eyes, hypertelorisms, and flat nasal bridge, a straight and thin nose, and pointed chin. The ocular involvement is very typical of the disease, with the finding posterior embryotoxin, which is a kind of collagen extending from the corneal stroma of this patient. It is not very easy to detect, especially in very young children. There's also a failure to thrive in this patient, and half of the patients fall below the 5th percentile for height and weight. The patient could be a psychomotor delay, and about the 30% of patients is affected by an EQ below 80. Cutaneous lesions are mostly characterized by itching lesions. Another typical characteristic of cutis of these patients are xanthomas, which are a manifestation of the severe dyslipidemia of this patient, especially in the one with severe cholestasis. So, summarizing, helpful clues for Alagille syndromes are heart murmur, especially if it is related to peripheral pulmonary stenosis, butterfly vertebra, common in Alagille syndrome, posterior embryotoxin, which can be detected by slit lamp exam, and renal abnormalities, which could be detected by abdominal ultrasound. Which tools we have to assess in patients with Alagille syndrome, considering the multi-organ involvement of this patient? So, hepatobiliary testing it is very important with serum biochemistry of the liver function, the ultrasound, and we can consider liver biopsy only in atypical cases or where there are concomitant liver disease. Also a transthoracic echocardiogram and a formal slit lamp examination, a plain X-ray of the spine or the examining of previous cross-sectional images. It is useful to not give more radiation to the patient. The clinical phenotype with very close clinical examination. The renal findings, firstly blood pressure measurement, but also serum electrolyte and creatinine, and protein to creatinine ratio, and the renal mass as well. What is really important is the cerebrovascular examination by brain MRI and angio MRI to detect the possible malformation with the risk of bleeding. And finally, the genetics of JAG1 and NOTCH2 mutation. It is important to underline that it is different in neonates, because neonatal cholestasis should follow a very specific diagnostic workup, which is mostly at the beginning related to exclude biliary atresia and also deficiency of alpha-1 antitrypsin. When biliary atresia is ruled out, we should detect through the research the mutation of the gene involved in genetic cholestasis. And in this case, the detection of gamma GT, it could be very useful to differentiate the intrahepatic cholestasis with high gamma GT to the one with low gamma GT. It is important to underline that Alagille syndrome is a cholestasis with high gamma GT. So the genotyping could be related to the detection of gamma GT. It could be very useful to differentiate the intrahepatic cholestasis with high gamma GT to the one with low gamma GT. It is important to underline that Alagille syndrome is a cholestasis with high gamma GT. To detection by next generation sequencing of the most common causes of genetic cholestasis, such as Alagille syndrome, progressing familial intrahepatic cholestasis, and bile acid defects. However, when it is not possible to detect this syndrome, the genotype should include the whole exome sequencing or the whole genome sequencing. In conclusion, when to suspect an Alagille syndrome? When the patient presents cholestasis, which is not related to an extrahepatic cholestasis with or when biliary atresia is ruled out. Cardiac abnormalities such as pulmonary stenosis and the characteristical facial features, which is easier to be recognized in older children and adults. The diagnostic tools are the symptoms, jaundice, pruritus, and failed stools. This is important, as I told you, to rule out biliary atresia. The family history, it is possible to find an autosomal dominant inheritance. However, it is important to say that this could be a disease with de novo mutation. So the family history, it is not always present. The lab investigation should include gamma GT, bile acids, and liver enzymes. The ultrasound is mandatory to rule out other causes of extrahepatic cholestasis. The liver biopsy can confirm bile positive, but it is not mandatory. And the gene sequencing is now the most important step of the diagnostic workup. The differential diagnosis is related to rule out biliary atresia, progressive familial intrahepatic cholestasis, and other cholestatic disease using imaging, biopsy, and genetic testing. So the best practices is to early refer this patient to specialists, liver, heart, or genetics for genetic counseling. So now please go on the next chapter where Amber Hiltred will discuss diagnosis of biliary atresia. Thank you.
Hello, I'm Amber Hildreth. I'm an assistant clinical professor at the University of California, San Diego, and I'm the medical director for liver transplant at Rady Children's Hospital, San Diego. Welcome to this chapter titled Best Practices in the Diagnosis of Biliary Atresia. So first, biliary atresia is a neonatal disorder characterized by an inflammatory obliterative cholangiopathy. It affects anywhere between 1 in 5,000 to 1 in 20,000 live births, and it's the leading cause of pediatric cholestasis, as well as the most common reason for pediatric liver transplantation. We know that biliary atresia has a very poor prognosis without intervention because the inflammatory and fibrotic obliteration of the bile ducts will progress to biliary cirrhosis by 6 months of age and ultimately to liver failure within 2 years. So it is crucial that we have a timely diagnosis for these patients. And to optimize the success of the treatment, which is the Kasai hepatoportal enterostomy, we want to ensure that this can be done within the first 60 days of life. And if we are able to do the surgery within that first 60 days, about 70% of patients will be able to establish bile flow. Now, after 90 days of life, less than 25% of patients will be able to establish bile flow. The North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, or NASPGHAN, as well as ESPGHAN, the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition, came up with a guideline for the evaluation of cholestatic jaundice infants. And this was largely geared towards, one, identifying biliary atresia early, but also evaluating for all causes of neonatal cholestasis. So the main goal of the guideline is to inform providers that any formula-fed infant who's noted to be jaundiced after 2 weeks of age should be evaluated for cholestasis with the measurement of both a total as well as conjugated or direct serum bilirubin level. Now, we do give a little more lean to our breastfed babies and reliable families that if we can wait until about 3 weeks of age, and at that time, if the infant's still presenting jaundice, to move forward with obtaining the fractionated bilirubin, which is the total as well as the conjugated or direct. And any infant who is found to have a direct bilirubin that's greater than 1 should be referred to a pediatric gastroenterologist or a hepatologist for further evaluation. So what are the key symptoms and clinical findings for biliary atresia? Well, first, of course, prolonged jaundice, but the biggest thing that we look for is acholic stools. And the most important thing for this evaluation is not just asking the family about the stool color, but really seeing it with your own eyes, whether it is a picture of the poop in on the parent's phone or taking a look at that diaper in clinic to get a visualization of the stool color. And it's important to also differentiate biliary atresia from other causes of cholestasis that you've heard about, such as PFIC and Alagille syndrome. For our evaluation, again, the main goal is to rule in or out biliary atresia in a timely fashion, as well as assess for other causes of cholestasis. So I'll talk about some of this evaluation in the context of a clinical case. But overall, it's going to include a variety of blood work and urine studies, imaging studies, and a liver biopsy, as well as a cholangiogram that for biliary atresia is the still gold standard ultimate diagnostic tool that we use. So for our case, we have a 4-week-old male who's referred to pediatric GI with persistent hyperbilirubinemia. The labs were notable for an ALT of 78, an AST of 98, GGT of 280, total bilirubin of 6, and a direct bilirubin of 4. Additional labs obtained on this patient was significant for an elevated MMP7 level at 93. He had an abdominal ultrasound that showed a normal appearance to the liver and the spleen. However, the gallbladder and the common bile duct were not able to be visualized. The patient then went forward with a liver biopsy, where findings showed bile duct proliferation with bile plugs, hepatocellular and canalicular cholestasis, and bridging fibrosis. All of this together is concerning for the diagnosis of biliary atresia. So after having that biopsy result, as well as the other lab tests, then we move forward to the ultimate diagnostic tool, which is the cholangiogram. So this patient at day 53 of life was taken to the OR, where the intraoperative cholangiogram was performed and confirmed the diagnosis of biliary atresia, and then the surgeons proceeded with the Kasai hepatoportoenterostomy. So, highlighting some of the lab findings in biliary atresia. Of course, we're going to see the conjugated hyperbilirubinemia. And of note and of importance is that the direct or conjugated bilirubin level in our patients with biliary atresia is elevated immediately after birth, because this is a process that starts in utero. And so this is a target for early screening and early detection for these patients. Also note that we're always going to see a high GGT cholestasis. So that's something to always look at, and that can help differentiate from some other causes of cholestasis. And then we now have a biomarker called MMP7 that we can use to identify patients with biliary atresia. And it carries a sensitivity of 94% and a specificity of 77% for diagnosing biliary atresia. Again, I'll say multiple times the importance of looking at the stool color. And there's been different ways that people have used stool cards to aid in a way of having early detection of these patients and really being able to identify those true acolic stools that should trigger that concern for biliary atresia. Probably the best example of this was in Japan, where they had over 300,000 infants that were screened with a stool card that was given to families on their 1-month well baby check. They identified a total of 34 patients in this cohort that had biliary atresia. And at that 1-month check, using that stool card, carried a sensitivity of 77% and a specificity of 99.9% in identifying biliary atresia patients. With this early intervention, they were able to achieve a mean age at Kasai portoenterostomy of 59.7 days, so hitting that target under 60 days with this stool card screening. Now, we use abdominal ultrasound as a part of our evaluation of cholestatic infants, but it's largely used to identify other causes of extrahepatic obstruction, such as a choledochal cyst. We may see signs of an absent gallbladder or absent common bile duct, but these are not diagnostic of biliary atresia. I also want to mention hydroscan or hepatobiliary scintigraphy, which is great in the sense that it can be 100% specific to completely rule out biliary atresia if you see a radiotracer make it to the small bowel. However, it is not diagnostic of biliary atresia, as lots of causes of neonatal cholestasis can have an abnormal hydroscan. And it can lead to delays in care. So most centers require 5 days of phenobarbital in order to maximize the excretion of the isotope, but this can lead to delays of getting to either a liver biopsy or the cholangiogram and ultimately getting to the hepatoportal enterostomy. So overall, we do not necessarily recommend HIDA scans as a routine part of the evaluation of patients with neonatal cholestasis. Now, liver biopsy is still a really important diagnostic tool that we use to identify biliary atresia, as well as other causes of neonatal cholestasis. In the hands of an experienced pathologist, the interpretation can lead to the correct diagnosis as to the cause of neonatal cholestasis in 90 to 95% of patients. Specific to biliary atresia, we are looking for signs of cholestasis, of course, but we will also see specifically bile duct plugging, bile duct proliferation, and usually advanced bridging fibrosis, since this is something that starts in utero. Some centers are able to do percutaneous cholangiograms at the time of liver biopsy if you can see a gallbladder on imaging, and this is a nice way to rule out biliary atresia without having to go for an intraoperative cholangiogram. Still, though, even after all the blood tests we have and the liver biopsies, the ultimate gold standard to confirm the diagnosis of biliary atresia is the intraoperative cholangiogram. And so this is done by our surgeons. And then once they do the intraoperative cholangiogram and confirm the presence of biliary atresia, they will move forward with the hepatoportal enterostomy or Kasai procedure. Now, when we look at outcomes, we've been able to look at large cohorts of biliary atresia patients and see that about 50% of infants will have a total bilirubin less than 2 during the first 3 months after the Kasai procedure. We also know that transplant-free survival at 2 years post-Kasai was significantly higher in the group who was able to achieve a total bilirubin less than 2 versus the patients who still have a total bilirubin greater than 2. And infants with a total bilirubin greater than 2 had problems with diminished weight gain, greater probability of advanced liver disease findings, including developing ascites, hypoalbuminemia, coagulopathy, need for liver transplant, or even death. Infants whose total bilirubin does not fall below 2 within that first 3 months post-Kasai are at the highest risk of early progression of their liver disease. And so from this became our recommendations of referring these patients for liver transplant. Now, specific to biliary atresia, we have a couple of reasons that we consider liver transplant. First is in those patients that fail to establish bile drainage, we call those patients the failed hepatoportal enterostomy. So that is an indication for transplant. Other indications for transplant in biliary atresia include a late diagnosis. So patients that most centers, if the patient's presenting greater than 90 days of age, really moving forward with that hepatoportal enterostomy is not going to be able to establish drainage due to presence at that time of likely cirrhosis. So those patients are typically listed for transplant as their primary intervention. And then our biliary atresia patients are also at risk for bacterial cholangitis. And in patients who have multiple infections or develop multi-drug resistant organisms, have life-threatening sepsis, all of those are reasons in and of themselves to move forward with a liver transplant evaluation. I hope that during this chapter, you learned that biliary atresia is the leading cause of pediatric cholestasis and the most common reason for pediatric liver transplant. Early diagnosis is absolutely key, as the Kasai procedure, if performed within 30 to 60 days of life, significantly prolongs life and postpones the need for liver transplant. Hope you know the importance of seeing the stool color with your own eyes for assessing the acholic stools. And finally, that for patients who fail to establish drainage by 3 months post-Kasai should be referred for a liver transplant evaluation. Please go on to the next chapter, where Dr. Eckhard Sturm will cover the concluding remarks for the entire program.
So let me conclude and thank the previous speakers for their contribution. I think that we have heard a lot about how we can address the challenges in diagnosing the cholestatic liver diseases. And we have understood that PFIC is a heterogeneous group of disorders that result from disruption of bile secretion. The elevated serum bile acids are a hallmark of this disease and a very important hallmark also following up on therapy. When we diagnose these patients, we can use liver biopsy still, but we have to keep in mind that we might have to do special exams with the tissue. Immunohistochemistry may be helpful in that regard, diagnosing PFIC in liver tissue. But of course, cholestasis gene panels and whole genome sequencing can confirm and help significantly with the diagnosis. Concerning Alagille syndrome, we should suspect Alagille syndrome in patients with persistent jaundice and 3 key signs. This is cholestasis, cardiac abnormalities, and characteristic facial features. For diagnosis, we have, of course, the family history. We have lab investigations showing elevated gamma GT, but we also do rely on gene sequencing, particularly focusing on variants in JAK1 and Notch in the 2 genes. We should really take care to rule out biliary atresia, and this can be done in specialist centers, and we have to keep that in mind, also to refer patients early in that regard. So for biliary atresia, this is more frequent than the other 2 diseases. We have to be fast in our diagnosis, fast and thorough, because we want the Kasai procedure to be performed ideally within the first 60 days of life. Very importantly, we really have to make sure that the stool color is well evaluated, and it's best to take a look at the stool color with your own eyes, and you might compare with what you have on the stool color card. But very importantly, try to see the stool color with your own eyes, and make sure that patients who fail to establish drainage by 3 months post-Kasai, they should be referred for liver transplantation. So I thank you for listening to the talks, and I'd like to guide you further to the questions. Thank you very much for listening, and I hope you've enjoyed the presentations.
This program was presented by Medscape Education Global.